we would be having, yeah, tomorrow we would be having a recap and introduction, which would be followed by an oral presentation for of 5 participants. We would break for 10 minutes and then we would have an expert panel on knowledge for just health system. We have 4 panelists who would dwell on different topics such as radical listening, participatory action research, and other such topics would be covered in the panel tomorrow. So hoping most of us could join today and tomorrow. So without further delay, I would go on to the next session. This session is moderated by Dr. Prashant NS. Dr. Prashant NS is a, excuse me, yes. So Dr. Prashant is the director at Institute of Public Health, Bangalore. He also leads the health equity cluster at the institute. He has a lot of experience working on primary health, and currently he is working out of BRT Tiger Reserve in southern India, and has been working a lot on tribal health. So over to you, Dr. Prashant.
Thank you. Thank you, Ketki. And I hope I'm audible, Ketki. If you can give me a thumbs
Yes,
up. If I am.
yes,
Yeah.
yes, you're
Thank
audible.
you. Thank you and welcome to all of the participants who have been able to join this pre-conference, which is like a build-up to the Nagasaki HSR 2024. And thank you to all the organizers for making the effort to bring together keynotes as well as lightning talks to kind of get us thinking towards the very important theme that HSR Nagasaki is going to be delving into. Before introducing Anant, which I will do next, I wanted to make just 2-line remark on the very important topic today on centering people. Because health systems discussions can often become so much technical into how we need to get high quality and evidence-based care to people that we forget that the larger purpose for which health systems are organized is for the people. So the idea that people have to be at the center and all kinds of people that make up our diverse society have to be at the center of the design of health systems is today's keynote talk, followed by lightning talks. So today's keynote is going to be delivered by Anant Bhan, who is well known in various circles within health systems and outside for his work on bioethics. Anant is a researcher with interest in global health, bioethics, mental health, and health policy. Lot of his work is based in India. He's trained as a medical doctor and has a master's degree in bioethics from the University of Toronto. He works from the Bhopal hub of an organization called Sangat, which has done exemplary work on community mental health and global mental health, and also in terms of access to equitable mental health care, etc. So Sangat Bhopal has a strong focus on health marginalization and health system strengthening and capacity building for mental health delivery. He is an adjunct visiting professor at Yenapoya University in Mangalore in southern India. And he's been the past president of the International Association of Bioethics, which has largely been because of the body of work he has done globally on the field of bioethics. He's also focused on equity in health, mental health, digital health, etc. He's been a resource person in training programs. He sits on several global and national committees, and he's the section editor on PLOS Global Public Health. And for many of those in India, we also have seen him quite active on X, formerly Twitter, and of course on various print and national media. So Anant, over to you for what I'm sure will be a very insightful session and a stage setting for the lightning talks and interaction that will come next. Over to you, Anant.
Thanks a lot, Prashant. Good morning, everyone. I am certainly very delighted to be able to join you today to speak to the topic of centering lived experience in health systems. As Prashant said, I think this hopefully will be a session which will give you some insights around why this topic is important. I know all of you are doing some really interesting work in the region and as a field which is growing, health systems research perhaps is a field also which needs to keep the idea of lived experience in mind as the field develops and as we continue to do some really interesting work with an idea of building on health equity initiatives, of making care available, which is of quality to communities in our region. So towards that, the way I structured my talk is to actually speak about on my own personal journey in terms of my interest in lived experience. And then I will maybe touch on a little bit around the work we've been doing in Sangat at the Bhopal Hub, and also the work around mental health. And hopefully that will give you some insights around how this could be approached. I think we are certainly still learning as to how to do things right, but hopefully that might spark off some thinking in your minds around what could be done at your own level, in your own organizations, and with your own health systems. So I'll just start sharing my slides. And Prashant, you confirm that you can see the slides, right?
Slides are seen, not yet in full screen mode, Anant.
Yeah.
Yes, I can see. Yeah, you're good.
Full screen. All right, great. Thank you so much. So, as I said, the focus of the talk would be on centering lived experiences, and this sort of draws from work that we've been doing. Now, if you look at the Lancet issue, which just came out the previous Friday, you would have seen that the cover page spoke about the fact that there is some really interesting science happening in oncology, right? And a lot of this science actually focuses on things like molecular testing, on complex biotherapeutics, on looking at how can we get novel therapeutics out quicker, faster, maybe sometimes even cheaper. But I think this cover page makes an important point. And the point is about what does really matter to the patient for whom we are doing these trials purportedly, right? And as clinicians and researchers, shouldn't the aim of the research that we do be about helping the patients with these conditions live longer and have better quality of life, right? And shouldn't hence the primary endpoints for the trials be about survival and quality of life improvement, which is really the real world issues that we have to deal with when you're doing oncology care, right? So if that is true of oncology, I would tend to think that kind of person-centered approach, patient-centered approach, and community-centered approach is something that we should see in all forms of research, including health systems research. And for me personally, I think as someone who trained in medicine a few years ago, when I underwent a foot injury and I was admitted for a while, underwent a surgery, and then I was temporarily disabled for a few months, had to use a crutch. And that at that point of time, there was this recognition, because when you are a provider versus when you're a patient, that transition when you're on the other side makes you aware of a lot of issues with the way healthcare is delivered, including how there are power inequities, how you might be looked down upon, talked down to, how in the health system consent in the way we imagine it is very different in the way it is actually implemented, how patients are looked at, they are treated, but sometimes perhaps not in the way that you would want yourself or your family member to be treated. And it's only perhaps more apparent when you're on the other side. So this was in the economics field, but Nandita was also a survivor of India TB and underwent hearing loss because of the second line therapy that she had to undergo. And so with Nandita, I wrote this article in the Times of India, which spoke about the issue around of learning from the disability community, that we really need to ensure that whenever medical decisions are taken, they are taken with patients and involving patients, right? So it is a form of shared decision making, which is important and crucial. And this should be true of any form of health systems involvement, whether that be at the level of a macro decision or at the level of the individual patient decision. And that should be something that we should all keep in mind. Now, there has been a lot of narrative writing, which I think we can all learn from. This is a narrative which was written by a psychiatrist who is a person with physical disability, and she speaks in JAMA Neurology. She writes in JAMA Neurology about being a teenage medical student with disability, and she talks about when she was sitting in class and listening into lectures and seminars or in medical education, she would hear our colleagues, our faculty members speak about disability in a very disparaging manner. And people making statements like, well, if I ever get that, you should just kill me. I wouldn't want to live like that. And she would, of course, be very upset. And also spoke, writes about the fact that faculty members would talk about the fact that if there was a diagnosis like this in a in a fetal scan, then the parent should go up and do abortion of the fetus, etc. And this was a person obviously with that same condition who was a medical student in class. And so the question then is, was there something wrong with her, or was there something wrong with the way medicine is practiced, right? And is the problem us, right? Rather than her. And if that is really the paradigm we need to talk about, then we really will start speaking about the importance of recognizing lived experience. Because when people with conditions speak about how they feel externalized, how they feel violated, how they feel stigmatized in the way the health system treats them, then we will start learning about why is it that access to healthcare sometimes is challenging? Why is it that sometimes communities are reluctant to access and come to health systems, even if you have care available, right? Where is the trust deficit which often comes through? And so it's extremely important, hence, to listen and to be keyed into these issues. My other learning also came from my own intersections with mental health. So as part of a project called Essence, where we were doing a randomized control trial, which was focused on depression care in communities. We also had a section of the project, which was our capacity building arm, where our understanding based on prior work was that you cannot just change the way mental health is being implemented by only doing randomized control trials, right? You also need to talk to other relevant stakeholders. So we were doing capacity building for media professionals to ensure that they did sensitive reporting in mental health. We trained implementation scientists, especially public health professionals. We worked with policymakers, but there was also a component where we were working with persons with lived experience. And this was a course which was developed with the Schizophrenia Awareness Association in Pune, which focused on service users and caregivers. Now, this is an important point, I think, for all of us to remember, that lived experience is not just about the person who has the condition. It is also often about the person who has to provide care to that individual and or individuals, especially in chronic conditions, because the caregivers also are important persons with lived experience. And so this was a course we developed where we worked with service users and caregivers in mental health and tried to understand what they should know about their own rights, how are they made aware about the Mental Health Care Act, which is an important health legislation in India, about what they can do, what they should not do, what to look out for in terms of how a mental health professional treats them. But also importantly, we learned that for persons with lived experience, some of the larger issues are as important as the medical issues. And so, for example, we ran a webinar with Vijay. Vijay is a leading mental health activist, a finance professional, and the founder of Bipolar India. And he ran a session on basic financial planning for mental health service users and caregivers, because that was identified as an important need. And we might not see that as a health need, but it is an important need from a social determinants perspective, right? Because persons with mental illness can often struggle with being able to manage their finances, etc. And so this is again a learning opportunity for us in terms of what matters to our patients and our communities. We also learned from lived experience of policymakers. When we started engaging with policymakers, there are policymakers who have spoken openly about their struggles with mental health. Shubrata is an IRS officer who's written a book on her experience with dealing with depression, and she spoke in this webinar about how she's used her own experience in terms of doing advocacy around mental health, in terms of opening up conversations, trying to destigmatize mental health. Uma Mahadevan, a senior IAS officer from Karnataka, spoke about her own experiences of working at community levels with Anganwadis and also of intersecting with the health system and health system officials and trying to see how we can also recognize the efforts of frontline health workers. And again, a lot of learning there as well in terms of the importance of lived experience. Now, COVID, I think, is another sort of whole experience where this whole engagement of people and their own intersections with health conditions became apparent. Many of you would know that long COVID was largely um, talked about because patients who had survived COVID started speaking about long-term symptoms that they were dealing with. And that was a large range of symptoms, as you know. And only through their, again, continued advocacy and speaking out, especially on social media, was there then a push for the medical community, for the health systems to be able to recognize long COVID as something which needed to be looked into. And of course, there are now writings about how that has gone through. There is a strong community of individuals who self-identify as having long COVID, who have coalesced and who have then started doing advocacy in terms of also writing to individuals running large studies about the need to look at longer term symptoms, signs, conditions, responses for persons with long COVID, right? And that's a good example of how patient communities, patient activism can help understand the experience of having a health condition better. Now, in terms of what does it really mean to have lived experience, right? So you have a definition certainly which is widely used, which is someone who has experienced themselves through individual knowledge or understanding or learning by virtue of having their own experience of a condition, right? So these are individuals who are usually called as persons with lived experience, sometimes also experts by experience, persons having lived expertise, patient experts, etc. And very interestingly, last year, WHO came out with a framework for meaningful engagement for people who are living with NCDs, mental health and neurological conditions. And it's a very interesting and a relevant document. I would certainly urge all of you who have not already accessed it to certainly do it. And it speaks about a lot of these issues that we have already started discussing, right? So it speaks about key principles which should guide engagement with individuals with lived experience, such as dignity and respect, the need to focus on power and equity issues, the need for us to be inclusive, especially because there are intersectionality requirements. Persons with lived experience of mental health might also be from a marginalized community. They might be socioeconomically deprived, etc. So the various identities which individuals could have, which influence their experience of a health condition, is being highlighted as being an important principle to look at for us to be committed and transparent in the way we engage with individuals with lived experience and how we also need to institutionalize this kind of work. And of course, linking that to financing, redistribution of power, elimination of stigmatization, integrated approaches, capacity building, engagement at the institutional level, all of which are principles and enablers, I'm sure, which you have talked about in your own work in health systems, and you use that as frameworks, and then how that can guide action at various levels. Now, there is certainly a long history around lived experience. There has been a lot of work, as you all know, around the development of rights-based approaches in the health sphere. Article 12 of the ICESCR specifically speaks about the participation of populations in all health-related decision-making at the community level, at the national level, at the international level. And hence also the language has shifted largely from earlier patient-centered care to now more person-centered care, which is inclusive, stigma-free. And you have to also credit movements such as the HIV/AIDS movement, where there was a lot of activism from persons living with HIV, which talked about the importance of working with them, engaging them in devising research ideas, in conducting research studies, in terms of implementation of programs, in terms of looking at stigma as an important issue. Also in the mental health field, if you look at the Quality Rights Initiative, which WHO has championed for many years now, that also again focuses on a rights-based approach to mental health. And certainly the disability rights movement, as I spoke about earlier as well, with a strong convention backing it up, and the CRPD, which again speaks about the need to respect and work with persons with disability and not treat them instrumentally or talk down to them. And of course, there's a large and growing literature on community and public engagement, which also talks about participation as being important. Now, unfortunately, the way health systems and also classical research paradigms are framed, usually expertise as it is treated is by virtue of a kind of a professional training or training by doing maybe research, right? So the prefixes of before your name, doctor, or a postfix like a PhD matters more perhaps than anything else in being able to do research or in being able to drive health systems. Lived experience is not valued as much, and I would tend to argue that that is a major gap. And the fact that power inequity still exists. Health systems and health providers have largely the power and not communities and users of services. That also is a problem. So if you want to change that around, right, we want to make it more equitable, then participatory approaches could be one way of doing it. And what are participatory research approaches, for example? These involve collaborations. These involve equitable involvement of communities in all aspects of the research process. Now, that is just the definition. How do you actually make it happen, right? And so there are certain principles for in CPPR. One is, of course, knowing what your community is, building on the strengths of the community, ensuring that partnerships are framed in a way that they are equitable, that there is cross-learning happening. It's not just for one group to learn from the other. They should be learning on both sides, ensuring that the knowledge that you gain from that partnership is actually used for action on the ground to bring about change. There is a focus on systemic issues and not just on a micro issue which you might be dealing with, for example, in a study. This is an iterative process because there is a lot of learning, unlearning, and then you keep applying, and that is true of health systems as well. There has to be a lot of cyclical approaches in the way we learn in health systems and apply our learning. Of course, it's equally important to disseminate, including to the communities that we work with, and ensure that any kind of changes that we are talking about are sustainable and happen over time. And so what I will do is maybe spend a little bit of time speaking about our own experiences in Sangat, especially the Bhopal Hub, and how we've approached some of these issues. The first section I will speak to is how we've tried to look at equitable partnerships for centering lived experience. And this has been, again, a process. We're still learning, but we've tried to bring about some change. The first thing that we've done is in terms of our own teams, right? And specifically within the I Hear initiative, which is a subgroup within Sangat Bhopal, where we work on health marginalization and health equity. We have slowly over time, iteratively, developed a team which is representative of the communities that we work with. So a lot of our work is with queer, trans communities, persons with disabilities, and most of the members of our team actually are drawn from these communities. And we proactively seek new team members who can help bring lived experience to the team. They also bring a lot of professional expertise. They bring in a lot of domain expertise and bring in certainly a lot of experience and engagement and community connects. But very importantly, when you construct teams, it's important to keep this in mind, that your teams should ideally be representative of the communities and populations that you work with. And similarly for your collaborators, right? We've really been lucky and honored to have collaborators who, again, are drawn from communities that we work with, who are champions and leading activists in this area, who also bring in their own lived experience and professional expertise and help us as a team to be able to focus on the kind of science that we do, on the kind of engagement that we do, on the kind of implementation that we do. And that has been really useful for us. We've also taken approaches such as setting up community leadership groups, community advisory groups, again, drawing from communities which relate to the project that we are working on or projects that we are working on, having long discussions with them in the formative part of research studies, in the implementation phase, involving them a lot in the implementation, and of course also in being able to interpret the findings in a way that they are respectfully communicated and that they are in the interest of the community in a way that, again, that whatever recommendations that we make are also going back to the community and are also recommended to policymakers to be able to bring about change. And towards that, of course, a lot of workshopping happens where we try to learn from community members, work with them, try to identify how we can co-create new programs, new research studies in a way that it is not violative. It is not, again, going back for purely extractive purposes where you want to collect data because you want to write a publication. get your next grant, and then you forget the community, right? And this is something which we were made aware of multiple times by the community, saying that that is the classical research paradigm. Researchers such as you have come to us and asked us the same set of questions, and you all move on, but nothing major has changed for us. And I think that was an important reminder for us for the need to bring about change. So these workshops help us really to understand things better. I will just play a small video clip from a colleague who is part of the team and is 100% visually disabled, Bhakti, and she speaks to her own experiences and also why this is important for communities here.
Hello everyone. My name is Bhakti Ghatole. I'm currently working with Hari in vaccine equity and I'm 100% visually impaired. So talking about participatory research, often it is seen that researchers identify the problems and then they themselves come up with the solutions for the community. And this exact notion is challenged by the participatory research, where they emphasize that the researchers need to identify problems by involving the community and collaboratively design solutions for them. So during vaccine equity study, we were also trying to understand vaccine hesitancy, and often trans and disability communities were blamed that they are not coming on the center and taking the vaccination. So it was assumed that there is some kind of hesitancy, some kind of fear within these two groups. But when we interacted with them, we found that there were so many different levels of challenges, including informational, transportational, infrastructural, because of which even if they wanted to, they found it so difficult and challenging to step out of their houses and go and take the vaccination. So it is not possible to unlearn ableism and heteronormativity within one day, and therefore it is important to have continuous dialogue with the community, especially when we are conducting research, when we are planning interventions for them. So somewhere that became possible when we were doing vaccine equity study. We had community members as collaborators, advisory board members. We could also conduct some workshops with them. And then the research process, not just remained about what to ask, but it became also about how to ask and how much to ask. So I feel that nothing about us without us, it should be the lived experience of all our research participants. And if we want to move towards health equity, then we need to have equity in the process itself. Thank you so much.
Take picture. Stop recording video.
All right, so hopefully that gives you a snapshot also of why this is important. I mean, Bhakti would have said it much better than I could potentially say it. So, what we've tried to hence do in our work is try to center lived experience through some of the methods. And this is because, of course, a lot of the experience which was shared with us in the qualitative research that we did spoke about the problem with the health systems. The fact that there is constant misgendering, there is discomfort, there is stigmatization, which happens to individuals who come from marginalized backgrounds, who are not made to feel welcome, and hence are not able to access healthcare, pointed to the challenges and the fact that hence a lot of these communities avoid public health systems and hence are, they're just not seen. So many medical graduates from India and maybe most other countries in the region graduate from medical schools without actually ever seeing a trans person or interacting with them or understanding their health needs, because the community just doesn't feel comfortable coming to these large tertiary care institutions. And this is, again, because the health system is a reflection of the larger society, and the societal challenges are reflected in the way the health system operates, right? And the fact that individuals who are persons with disability, in this case, a woman who was a wheelchair user said that, that she was well above 50, but never in her life had she even had one gynec checkup happen, because there were no accessible examination tables where she could be lifted up from the wheelchair in a respectful manner and be given a gynec examination, which ideally should happen on a periodic basis for every woman, right? So hence pointing to, again, the challenges. As Bhakti was saying, a lot of our finding in the vaccination space in one of our projects pointed to the fact that a lot of touch points in the health system are inaccessible, they are out of reach, they are not designed for someone who might be coming from a marginalized background. Digital registration portals are not designed for persons with disability. The mandatory ID requirement for vaccination, which was there during COVID, might exclude those who don't have ID cards for various reasons. Transport was often not available, especially during the lockdown period. Vaccination centers sometimes were on the fourth or fifth floor of a hospital, which did not have a lift. So someone with a physical disability would struggle. Home vaccination services were not made available even for individuals who were immunocompromised, having a lot of chronic conditions. And perhaps most importantly, the fear of mistreatment, of not being treated as in a respectful manner, was also keeping away communities from accessing vaccination, which was a crucial public health intervention, as you know, during COVID. So, of course, we can learn a lot from qualitative methods, but what we also have learned is that we also need to co-create some of this learning with communities. And so we've tried in our work also to use innovative methodologies such as photo voice stories to be able to document the experience of trying to access healthcare as a person coming from a marginalized community, and use that to be able to make the point. And these are communities speaking for themselves and documenting their own experiences. So in this case, Abha is a wheelchair user, leading disability rights activist. She was one of the individuals who were part of our photo voice story cohort, and she documented some of her own experiences. A small audio clip from her.
So when I agreed to take part in this project, I was very much excited that I would be able to create some awareness among persons with disabilities, that how can they self advocate for themselves for home based vaccination. So I agreed to take pictures and send pictures for the project. But while taking pictures, I faced certain challenges because I could not go out myself sometimes, and I had to take help from my family members to take the pictures. But yes, the overall experience was great. I could compile different pictures and tell my own story of taking vaccination and the various kinds of hurdles and the success that I got while getting the home based vaccination. In my district, I was the first one to get home based vaccination. So the whole project was very interesting, and I loved taking part in it. And I hope more of such projects they do come along. And as a person with disability, I would be able to contribute in awareness generation.
Right. So again, a lot of our participants in the photo voice story, like Abha and Naz, spoke about how the process allowed them to express themselves. It also allowed them to document their lived experience, highlight some of the hardships, as well as the successes, the positive enablers which the communities had in terms of their intersections with health system. And this is, I think, part of the co-learning part, which is important, because usually in our own scientific specializations, including HSR, which is now also growing, there's a growing body of work, there's a lot of publications, there's a lot of work happening. We need to be cautious about the fact that, the jargonism that is inherent in the way we practice our sciences, and the language that we use can also result in power inequities. And hence, how do you challenge that in terms of co-learning? Some of our approaches have involved thinking about the medium to long term. How can we work with communities to build leadership within communities? So, we work with a cohort of young, early career professionals, individuals, students who hail from the communities, who were interested in learning about advocacy, in learning about research, so that over time they will get the skills and hopefully become the champions of identifying and responding to health needs within their own communities. And this hopefully will be part of the change that we should be seeing, where we're not seen as these external research groups which do helicopter research on communities, but actually are researchers working with communities to enable them to be able to identify their needs and be able to work on them. And hopefully this will be a transition that we see across the board, including in the field of health systems. Now, part of what, as I said earlier, is important for advocacy purposes, both with the communities as well as with policy, is dissemination. But how do you design dissemination to be inclusive, right? And that has also been a learning process for us And how do you do it in a way that community members are again highlighted center stage in the way we do it. We've done it for some of our projects by coming out with community briefs in different languages, in coming out with policy briefs, in running our exhibitions in venues where communities are invited to learn from the narratives that have been documented. We've also put up our exhibition online in accessible format, so that individuals who are not able to come in person are able to view it in the website, and it has audio snippets, etc. It has text-based snippets so that individuals with various forms of disabilities are able to access it. We've run large events in venues where we ensure that these are sensitive venues where no one is stigmatized, no one is made to be feeling unwelcome, where again the voices of the communities are brought to the center and again highlighted in a way that while the research findings are important, the perspectives are equally important, and also giving opportunities and championing our team members who are again professionals, but also community members, and supporting them in being able to share the findings of the research that we do, of the findings that we have, and also running events where we bring together various stakeholders, medical educators, community members, NGOs, policymakers to try to advocate for change and allow people to freely express themselves and be able to speak about what kind of change they'd like to see. And also, while we do all of this, some of our own thinking also has been about what we need to do differently in the workplace, in organizations such as ours. We've done this large suite of projects in the I Hear initiative, as I spoke about, and what we've tried to do is, as I said, build a team which is now largely based out of Bhopal, but also then see how do we ensure that we also bring about some change in terms of the landscape in Bhopal itself. We've run events where we've tried to engage with young people and speak about the work, the need for inclusivity, diversity, the need to talk about how communities need to be respected, how we need to deal with stigma, etc. And also in terms of our own policies, we up as an organization a trans and intersex equal opportunity policy. We run sensitization events so that the organization also brings about some level of transformation. We brought in mechanisms where people who are, for example, having a disability are provided people working hours, work from home. We have an inclusive menstrual leave policy, so that allows for individuals, any individual, able to access this policy. We have a policy on disability inclusion in development. We have a mental health policy in development. So within the organization, also trying to bring about change. And also in our work, as Prashant alluded to, we've been doing a lot of work with frontline health workers on community mental health. And one of the things we have learned through the work with them is that they've highlighted that their lived experience also needs to be highlighted. That while they are often used as mediums to be able to deliver some form of healthcare to communities, but their own intersection, their own health needs, their own requirements of mental health and well-being are not dealt with. And that inspired us to also work with them to develop a project which focuses on ASHA worker mental health and well-being. And there's been a lot of learning from that project as well. So I think, the communities that we work with, the health system providers that we work with, all of those are individuals with lived experience whose experiences need to be counted in, recognized, and learned from, and seen as mechanisms for us to be able to do better. And that work, I think, hence, hopefully will slowly over time, if it gets institutionalized and becomes sustainable, create impact in communities as ASHA workers or other frontline health workers recognize their own mental health needs, recognize the mental health needs of their communities, and start acting on them. So I'll maybe leave you with a few recommendations based on what we have learned over the last few years of work. One is the kind of language that we use. It's important to learn from communities as to what is respectful language. A person-first language is something that the communities expect. So it is a person with lived experience, a person with a mental health condition, a person with a psychosocial disability, rather than making the condition the adjective for that person, right? It's not a disabled person, it's a person with disability. It's uh, a schizophrenic person, it's a person with schizophrenia, right? Things like that, where it's a person first language. We should also be cautious about treating this as something which is tokenistic, something which is a checkbox in our research approaches. We need to recognize lived experience as a form of expertise, which means that in the same way that you would pay an expert, a professional expert, um, for an engagement on your research study or on your health systems project, you should also remunerate individuals with lived experience. We need to engage right from the planning stage, not as an afterthought, not as a post facto decision. But when you're thinking about what you want to do from a health systems perspective, from a research perspective, involve communities, involve persons with lived experience right at the beginning. But towards that, also make them feel comfortable, right? So create those safe spaces where they feel respected and have the trust to be able to share. Because unless we have those perspectives feeding into what we want to do, we will not be able to really respond to the needs of the communities, and also invest in creation of capacity so that the language on both sides is more equitable, where they understand what you're saying minus the jargon, and you understand what they're trying to communicate. So you also learn, they also learn, and there is some mutual capacity building happening. And especially from a reforms perspective, ensuring that this involvement is really, again, integrated across the way that we function. A lot of funders now are also insisting, for those of you who are looking out for funding, who want to write research projects, funders like Welcome have made it very clear that they expect lived experience to be recognized in the research proposals, and you have to actually make a case why you don't have lived experience represented in your research project and your collaborator list, especially in the mental health space. So you have to justify why you're not actually doing it, because the norm is to actually have lived experience represented. In fact, they have individuals who are members of the lived experience team. Kate runs that team. She's the head of the they are the head of that team, and hence this shows that many funders are also now increasingly paying attention to this as an area of work. And there is a growing literature also around lived experience, especially in the mental health space, but also disability, other forms of marginalization. So as a community focused on health systems, it would be useful for all of you to also learn from that literature and try to see how we can again integrate a lot of that work in the reforms that we're bringing about, in the proposals that you're developing. And Welcome has a very good useful guidance document, which is also freely available, which is focused on mental health, but it could be true of any other area as well, where lived experience is supposed to be central to guiding how the research project is designed, implemented, monitored, where individuals with lived experience are involved at all stages of application writing, where they're recognized as experts, where you also recognize that just having one or two persons with lived experience might not be enough, because there is a diversity of lived experience, and individuals with one form of disability might not represent other forms of disability, for example. And you need to compensate for their engagement, acknowledge their contribution, treat them with respect, and not as research participants, right? So they are collaborators, they are co-investigators, and involving them needs to engage, needs to have them engaged in a respectful manner. And so you could have them formally named as co-investigators, collaborators, advisors, involve them in a lot of project design discussions, data collection, analysis, as well as reporting and dissemination, in a way that this again recognizes their crucial role on the projects that we do. I will leave you with some thoughts from Sharon, who is also a member of the team, and as as again highlights in our comments that it is important that we think about the ways in which medicine research and policy are systems that are entrenched in upholding stigma against marginalized communities. And once we understand that legacy of harm, ableism, homophobia, transphobia, casteism, we can perhaps start thinking about a more affirmative health system. And participatory approaches can help us perhaps understand things better and reflect critically. So hopefully this is the kind of learning that all of us can take to heart and try to develop interventions, responses which are more respectful of the communities that are at the heart of our health systems. And thank you for your time. Hopefully that gave you some insights around lived experience. Again, as I said, this is more of a personal reflection, and I hope that this will be useful as you think through the field of health systems and as it evolves in our region and the world. Thank you. Back to you, Prashant.
Thank you, Anant. Thank you very much for an insightful talk. And I think from what we hear, also this is also very contextual. And I think we hear the experience from Sangat Bhopal, and I think we need to then reflect on the different social identities and the context within which we work, and then see how we can imbibe these principles in our work, right? So thanks a lot. There are two very interesting questions. Maybe we can begin with that. And if there are others, I would really request those of you who are listening to feel free to use the question and answer tab to ask your questions. So maybe you can even potentially take the two together or separately, Anand. The first one is by Kranti Vaisaraju on mechanisms that enable equity to drive innovation, especially in the technology rich kind of spaces like diagnostics or vaccines. What could drive or enable equity there, which is more a general question, I think. And then Meena's question, which is much more specific. I invite everyone to see the Q&A. I won't read it all, but largely on how can we bring people's voices or lived experience in policy dialogues, which are heavily dominated by powerful actors. She uses the example, of course, of medical doctors, which is one axis of power. There are various other axes of power which seem to occupy policy spaces. So these are two initial questions to start off, Anant. Back to you.
Yeah, thank you for the questions. I think these are great questions. So to Kranti's question, equity needs to stop being a fancy concept, right? I think at the heart of whatever we do, we need to work for the communities for whom, for example, the innovations are being developed. If we say that we are developing an innovation, it is, of course, important to have the technology at the heart of it. It could be AI, ML, it could be a new diagnostic, it could be a new device, it could be a new innovation in the way health systems delivery is happening. But ultimately, why are we doing it, right? We are doing it because we want to make sure that something is more efficient in the way it is delivered, or something is faster, cheaper, is able to be done at closer to the community. And so you're able to provide healthcare in a more refined manner, and ensure people get screening or diagnosis or provision of treatment in a faster manner. And if that is what you want to develop the innovation for, then of course it is all equally important for us to ensure that it is done in a way that ensures that communities for whom we are designing that intervention are able to access that intervention, are able to also provide inputs on whether that intervention works for them. Many of us would have served on committees where we see an excellent idea, but a total lack of context. You might have an excellent idea, but it's never going to fly in the health system. It's not going to be operative at a primary healthcare center. You've designed something which will sit within a tertiary care paradigm, or in a place which has 24/7 water supply, electric supply, data connectivity, but you have refused to engage with what will work for a community in a primary health center or a sub-health center, right? And if an equity lens or the absence of it will mean that we will continue to have those kind of innovations, perhaps getting funded, perhaps being highlighted, getting all awards, but then, is that really going to bring about change? Likely not in the foreseeable future, right? Maybe it might bring about change for a community in a global north context, but certainly not in the context in which many of us operate, right? So hence, it's important to have that lens and speak about why it is crucial to ensure that innovations focus on being designed in a way that are responsive to the needs of communities, and also that we don't get lost sometimes in only designing for communities, keeping the macro at heart, which means to say that there are smaller subsections of the communities which have important health needs, right? Now, patients with rare diseases is a good example, because it might always be this question of, should we invest anything in rare disease research in a country like India? Or should we be only spending more money on NCD research, maybe mental health, maybe cardiovascular disease, maybe road traffic accidents, right? Because that's where the burden of disease is. But then what happens to those who are, who are suffering from rare diseases? Should we abandon their health? It's likely not, right? We have to find that balance. And an equity lens will tell us that those who are marginalized, for whom healthcare is not largely available, also require a focus, right? And especially also then marginalized communities who've not been part of the classical paradigm in the way health has been designed and health systems have implemented. So hence the equity lens is important because it tells us what is missing from the way we are approaching health. To Meena's question, how can we bring lived experience? I think, as I said, what I have recognized and learned, certainly learning from colleagues, collaborators, is that if we highlight lived experience, if we engage with lived experience, and we use those narratives to tell the story, that those are much more powerful than any papers that you and I might be able to write. Because a person with lived experience speaking about their challenges and about why they are reluctant to access the health system, why every time they've tried to access the health system, they've been marginalized, they've been stigmatized, they've been turned away, and what that means in terms of their struggles with accessing health system. And that one narrative could be much more powerful than 3 Lancet papers that we could write, right? And of course, it is not to say that we should not be doing research or writing papers, but it is also important to ensure that the stories behind that intersections with the health system are brought to the fore. And by working with persons with lived experience, by involving them as collaborators, by center staging their experiences, I think we can bring about a lot of change. And of course, sometimes it's difficult to break into these policy circles, which are very elitist and comprised of individuals who might be privileged. But it is certainly possible to try to do that by, again, involving individuals with lived experience over time and building that pathway so that their activism, their advocacy can bring about change. Because it's very difficult to say no or to de-recognize the lived experience of someone who speaks about the challenges that they've had. And hence, maybe that is one way of trying to dismantle the power hierarchies which exist and bring about change. Siddesh also asked, are doctors trained on why lived experience matters? Likely not. I mean, for all of us also, most of us who've been trained in medical schools, we know that the way we are trained often uses language which is ableist, which is sexist, which is discriminatory. And the same challenges that we see in the society around us are also reflected in the way medical systems operate. And hence, again, sensitization, ensuring that persons with lived experience are able to speak to medical professionals as they're being trained or retrained or getting their CMEs, and that there is a recognition of working with patients, not in a top-down manner, not by talking down to them, but in a shared decision-making framework. If we do that, perhaps, again, and build that trust with them, maybe we'll also see better health outcomes. And isn't medicine and health systems about ensuring all of that happens? And
if I may, sorry, finish that.
No, go ahead. Yeah, maybe you want to go ahead.
No, if I may, I thought we can take another question of Siddesh, and the question, I'll skip Shweta Singh's and we should come back to that. Karan's question, which now I think go into the tensions and the difficulties once you begin engaging with, respectfully and in a dignified, empowering manner with people with lived experience. And I think this will be very useful for those who are, for those who are opening their minds about engaging with people with lived experience. So, and both are very interesting tensions. Siddesh now poses saying, okay, what about grant writers and researchers who are driven by this way of evidence generation, which comes from, kind of scientific training, the way it is currently practiced? And what if there are, tensions between questioning some of the foundations of science as we practice it through an engagement with people with lived experience? And I would like to mix that with Karan's question, where she says, engaging with people with lived experience also, there's a lot of investment of time, emotions, etc. by them. And then dealing with the disappointment in the whole grant and all these ecosystems, are we, sometimes is it possible that we might raise expectations and not meet them? So how do you deal with these tensions, Anand? I know there is no golden, one-way answer, but insights would help.
Sure. So, I mean, I think one of my learning has been that the most successful community interventions, interactions, which research groups have had, and they're good examples of this, let's say the Kanyambadi block in CMC Vellore, the work with AIMS Delhi, Vallabhgarh, the work which many organizations, including IPH, is doing, long-term investment in building trustful relationships and partnerships with communities will help you deal with the disappointments which are more interim in nature. For example, you write a grant which involves community members and it fails. The community, if it knows that you are there for the long haul, you're not there just because you want to write a research project with them, that you have invested, you are present, you've been working with them, you've been trying to advocate for their rights. So these interim challenges will be seen as one of the various things which happen as part of a true partnership. But if the expectation is centered around, we will only work with you if we get this grant, right? Our relationship with you as a community is contingent on us getting the $1 million in our kitty. Otherwise, bye-bye Tata and I'll focus on something else, and write my grant with another community. Then, of course, then we have failed, right? Because then I don't think we're truly doing equity right or truly doing partnership right. So if we build long-term relationships and are transparent and honest about what is possible, what is not possible, and that over time, how iteratively you can build towards maybe a larger grant, but there could also be steps around doing things which are possible without a grant to start building that relationship. And part of the humility which should come in that is, of course, also listening, right? So that listening might involve things that you might not agree with, our classical evidence-based approaches or paradigms. And this is not to say that you need to change your outlook to believe in everything which is said, but at least you should learn, because there might be some experience in there which tells you why is it that they do not believe in a evidence-based approach. Why is it that they feel that doesn't work for them? And why is it that they prefer someone who offers a non-evidence-based approach? Perhaps because it is they get the time. Maybe it's more affordable, maybe it's more accessible. And that by itself tells you what is it that the communities need, right? And when you then design an intervention with them, hopefully you will try to respond to those needs and design your health systems, which might be evidence-based in a way that they respond to the needs that are clearly coming through. And then maybe they will also start believing the health system that you advocate for and build a trust towards it. So I think it's again, I think a lot of learning and also not, as I said, treating communities as folks to talk down to, where you think that, of course, they don't know anything. I am the expert who's coming in and we will solve their problems for them. Unless we build true partnerships, I don't think that will be a very successful long-term sustainable intervention. And that, I think, experience with various marginalized communities has shown across many research groups.
If I may, our learning has been about how many communities that depend on traditional healers were always looking for dignity and respect in their healthcare interactions, and they were not actually looking for cutting edge innovation or the best antibiotic which responds very well to a culture and sensitivity test, etc. So somewhere, that like you say, if that understanding creeps into the team, then through these interactions, that's also a win. Even if sometimes potentially this grant did not come, then maybe you move to something else where you go. So thanks for that, Anand. We have, I believe, a few more minutes, and the questions are now just pouring in. Maybe Shweta Singh's question, which we had skipped earlier, on how do you respond to a system which is sometimes steeped in, let's say, classical or traditional norms and roles, where your group might have advanced long distance in understanding lived experience, but you are working with a system which pushes back, doesn't want to hear these stories. So how do you ensure that this is not happening in a bubble within your group, but actually, any thoughts on that? Again, a difficult one, but
Yeah, no, absolutely. That's an important question, and we've also struggled with that. Some of our work actually has tried to address this issue from a perspective where we have recognized that we need to bring about reform in the way health professionals are trained. So we have now a whole range of projects which is focused on making medical education, other health professional education more affirmative in nature, both on the disability side, but also queer trans understanding. So we've done workshopping, we've developed competencies, some competencies which were developed earlier for a health professional to be able to provide affirmative inclusive care have also made their way into the NMC set of competencies. This is work which Satyendra led from UCMS. And so it's possible to try to bring about that change. We've run workshops in a variety of health professional education training spaces. We have active partnerships with the Maharashtra University of Health Sciences, where we're speaking specifically around disability, inclusive, compassionate care. We've run workshops in places like Government Medical College Srinagar, AIMS Guwahati. We've done workshops in the West. We've gone all the way down to Mangalore and Manipal and run workshops. And we again recognize that when you bring narratives, lived experience to the fore in some of these workshops, and you can, of course, give a very scientific presentation, but when the lived experience is shared, I think it makes the most compelling impact. And individuals recognize that there is a problem, right? And especially true also when you have health professionals who have lived experience sharing, right? When you have a doctor who's a person with disability, or you have a doctor who's a trans woman, or a doctor who's a queer identifying individual speaking about what personally they have underwent in those spaces and how they have felt traumatized, how they've felt unwelcome, how their health needs have not been recognized and responded to, then I think it makes it all the more apparent, because they know the system, right? You cannot say, oh, well, you really did not understand how to approach it. You should have done that. You should have done that. There are faculty members in medical colleges talking about how the system is still ableist, the system is still transphobic, queerphobic, and then I think people start listening in and they get keyed in. Of course, sensitization is one thing. Change in practice takes time, but hopefully some of these interactions will mean people start recognizing the fact that why is it that my busy OPD does not ever have a trans person attending that OPD. It cannot be the case that there are no trans persons in a place like Bangalore, right? Or in a place like Delhi. But if you're operating a busy OPD in a public sector hospital, why is it that they're not coming, right? If you start questioning yourself, you'll then maybe start retracing your steps and say, what is the problem? Is it the fact that they are turned away from the door? Is it the fact that your registration lines are heteronormative, right? Is it the fact that ID cards are required and they might not be available to individuals who are undergoing a transition, or that your buildings are not accessible, so someone with a physical disability will struggle with being able to get a registration card or be able to come to your room on the third floor? Then you will start understanding the structural factors, which where the health system has not been able to provide an inclusive atmosphere for individuals to access healthcare. So I think those sensitization sessions, but also then following up and trying to bring about design changes are important. We're just starting a new project this month where we are also going to do audits, access audits from a disability perspective of health facilities in Madhya Pradesh and Goa, and hopefully use that to advocate for change. And say if the health system is not inclusive, it's not a place where persons with disability can access care or be able to come, then there is a problem and you need to bring about change. Again, working with communities. So various steps. I don't think, we have, pure solutions here, but certainly working on the sensitization side, audit side, and developing training competencies, developing evidence so that people cannot say that where is the evidence that this is a challenge, right? So also developing the evidence, both qualitative and quantitative, and then building a strong community advocacy set of initiatives so that communities can use that evidence, use that learning to hopefully bring about change.
Very nice. And I think it goes back to that question, no? Ultimately, how do powerful institutions like medical colleges or health departments, rather public service departments, start asking these questions? We will have to trigger ways where this conversation happens in those large institutions as opposed to, happening only outside. So, Maybe the next one is a very interesting one. I think you already briefly alluded to it when you said about the need to internally move from saying, disabled person to person with disability, because the disability may be just one attribute of a person among so many other attributes that each of us share. So Rajalakshmi Ramprakash asks about conflict of views between people with lived experiences, because it's not only the lived experience that shapes an individual, but also other things which may be outside of the ambit from which we tend to look at some of them. So how do you deal with conflicts, differences, or any thoughts on that? How do you navigate these also when resources are limited, she asks?
Yeah. No, absolutely. That is important, but I don't think it's very different from disagreements within our conventional teams, right? Or our own organizations. Those happen all the time. You try to deal with it in a mature manner where people feel that they have been heard, where their perspectives have been factored in. And then you might come to a decision which is not in line with what they would like the approach to be, but there has at least been a due, transparent process where everyone has been engaged. And this again goes back to the question of ensuring that there is diversity. You cannot have one person with a lived experience and then claim that they have, they represent all forms of lived experience, right? So there is again a diversity of intersectionality that needs to be looked into. It might be challenging to, of course, get everything possible factored in, but at least you make a genuine effort by having a diverse community, learning group, advisory group, members of your own team. And a lot of these discussions should ideally also be initiated, hosted, run by members of the community who are part of your core research team, because it's much more likely that persons with lived experience will feel more comfortable sharing when they see a facilitator, when they hear a facilitator, when they engage with the facilitator, who is someone that they identify with or feel comfortable with, right? So again, it doesn't become a paradigm where they feel that you might again be asking questions for your personal benefit or for the organization's benefit, but it seems to be something which is driven with the community, by the community. And of course, these are there is no perfect answer here. All of us have made mistakes and learned from them, and disagreements happen. People feel you're not doing enough. People will feel that your group might be still doing something positive, but the larger paradigm of your organization or the larger paradigm of the research ecosystem is still violative. And that is true, right? And so some people will not want to engage with you, will not want to be part of these processes, and you have to recognize their opinion, and you have to be respectful of that, and still try to do the kind of work that you're doing in an open manner where you're learning from it. But again, it is not always possible to get everything right. But it's important to at least be cognizant and learn from from all of these processes.
True. I think many people who have done this work also share about the anger and outrage that will also come our way, because there is no perfect way of we are unable to do enough most of the time, also because of our institutional and social barriers, and that also brings the outrage and anger about not doing enough often. And I think it's very important to also deal with it in a mature way, where we accept sometimes that there is not enough done. Even though individually or organizationally we might be doing a lot, we often feel like, okay, there should be a lot of positive praise, which may not be forthcoming, but I think it's important to understand the larger context. So I think maybe I mean, there are a lot more questions. I don't know whether we can go to all of them. Maybe if you have a few more minutes, if there is anything else, some of the people may be early career researchers, others in the panel may be more experienced researchers. If you have any closing remarks or any messages or anything of that kind, if you want to share, otherwise we can move it back to Ketki.
Sure. No, I think we've had already maybe a rich discussion, and it's great to see a lot of people reflecting. As I said, I will not claim to be an expert in this area. I'm certainly a learner, a co-learner with all of you. It's important to get started. It's important to work with communities in an honest, transparent manner. It's important to recognize that the communities that we work with bring their own experiences, and that experience is a form of expertise that we should respect, that we should engage with, that we should learn from, and not do it as something which happens once the project is being implemented or your intervention is underway, but right at the design phase. Because ultimately, what are you doing the project for, or what are you doing that implementation for, or what are you designing your health system for, or the reforms that you want to do? It's for the communities that are at the forefront of the health system. So towards that, if we keep that as a core principle in heart, and we work towards it, then I think that's a good enough first step. And of course, there is a science that you can attach to it. You could find innovative ways of doing it better in your own context. So for those of you who are early career researchers, you could think of designs which allow for that engagement to be done in a more honest, transparent, equitable manner. And we could all learn from that, right? So we could all learn how to do better, just in the same way that, consent is an age-old practice in research, but we still all challenge with doing consent right. And we can all always still keep doing innovative approaches to doing, consent in a better manner. It's the same here as well, right? People have tried community advisory board, people have tried leadership groups, people have tried workshops, etc. Maybe there are different ways of doing it for different communities, for different contexts. And if we are able to do it and document and evaluate, then all of us could learn from that. So from your research perspective also, this could be another area that you could think of doing innovative research in working with communities to identify what is the right way to respectfully engage with the community, what is the right way to recognize and respond to lived experience, and center stage that in the work that we do. And hopefully with a growing body of science, maybe we'll all learn collectively what works in our regions and what are the kind of toolkits that we could use in a way that we can do things better. So hopefully over time, we could all do that. And maybe in your own conversations, in your own reflections, in your own presentations and projects, already start thinking about some of these approaches in a way that we bring about change at our own levels: personal, organizational, institutional, and health systems.
Thank you. Thanks a lot, Anand. And as you said, it was quite a rich discussion, and there is still many more lightning talks coming our way. So I request our audience to stay. And with that, I invite all of you to share a round of applause. Sadly, we are not all together. Otherwise, it would have been lovely to hear the close of the session. Thanks a lot, Anand, for sharing. And please do stay on if you can. And I'll pass back to Ketki to move the session along.
Thank you, Prashant, and thank you, Anand, for this engaging talk, and thank you, Prashant, for keeping to the time and exactly finishing it on time. So well done, and a very interesting talk on how to engage communities meaningfully in the research process. So moving on to the next session, we would be taking a break for 10 minutes and rejoin at 12 p.m. IST. That is in another 10 minutes, and we would start with our oral presentations and lightning talks from the selected participants from the Southeast Asia region. So see you all at 12 p.m. again, yeah, in 10 minutes. Thank you.
I'm Pratik Adhikari. I'm from Nepal Injury Research Center, Kathmandu Medical College, Nepal. Today, I'm presenting on behalf of the Federalization and Health System Project team. And the title of my presentation is about health professional perspectives on health service delivery in federal Nepal, or qualitative analysis. These are the team members involved in the project. It is the multidisciplinary team. Next slide, please. Nepal transitioned in 2015 from a central governance system to a federal state with 753 local bodies in 7 provinces. Under 2015 constitution, local governments are now granted both the local development policy formulation as well as program implementation responsibilities. The local governments now govern the local health system, making it imperative to engage them in policy formulation and build their capacity to formulate and implement those policies. Next slide, please. Today's talk more focus on qualitative findings, exploring health professional perspective on health service delivery in federal Nepal. And actually, we use the mixed method approach, but today's focus is based on qualitative primary data using key informant interviews. And our study participants were federal and provincial health policy level staff, locally elected politicians, health coordinators, health facility staff, and people working in the different NGO, journalist, and policy researcher. This study granted the ethical approval from Nepal Health Research Council and the University of Sheffield. Next slide, please. Secretary, next slide, please. Sorry. Yeah. So this is the map of Nepal, and we included. Sorry, previous slide. So we included the diverse, the geographical location of Nepal. We included district from the mountain region to the district from the southern plain land, as well as we also included the district from the hill, and we included Kathmandu as the main urban center. Next slide, please. So we used, the different interview questions. For example, how do you see the current health service delivery in federal Nepal? What differences have you seen in the current health system, federalized versus unitary? And the study is based on the 71 interviewees at different province and the local levels. That is all about the perception towards health service delivery. Next slide, please. And the key findings of our study lies on improvements in health system under federalism in terms of resource efficiency better, improvements in emergency services, financial support, and improvements in monitoring. One of the health coordinator from mountain district highlighted that there is a significant improvements in resourcing of health system, particularly buildings, equipment, and money. The quote he highlighted as follows: there are health posts and basic healthcare center in every ward as per the protocol of the government after federalization. This is one of its achievements. Similarly, another health post in charge who was based in the rural municipality in the remote mountainous district, he noted the improvement in emergency healthcare. He highlighted that the provincial government has facilitated helicopter services for pregnant women. Then she is referred to some higher center. For example, last year we referred to a pregnant woman to Nepalganj from Mangri Health Post by helicopter. Next slide, please. And the another findings lies about the areas of health system where more improvements are needed in terms of staff adjustment issue and medicine supply. One of the immunization officer who was based in the Hill district, that is in the Palchok district, highlighted the lacking skilled human resources in their local level. For example, he highlighted, I think previously it was easier to work since there was enough manpower, but in the present system, there is a shortage of human resources, so there is a high workload among the staff. Similarly, another health post in charge highlighted about the procurement and availability of medicines. He quoted, there is no timely supply of medicine, no proper coordination is seen between the regional medical store, central medical store, provincial level, and district hospital. Next slide, please. So there is a regional variations. For example, our research shows varied perception among health workers and improvements in health service delivery with disparities across dimensions and location as reported elsewhere. This study underscores the crucial role of physical improvements for effective healthcare, whilst at the same time reporting significant deficiencies in health facility infrastructure impacting maternal and newborn care. These perspectives highlight diverse challenges and success in health service delivery across regions. Next slide, please. So in conclusion, stakeholders have different opinions and perspective about federalized health service delivery. More resources were made available to health facilities and services were brought closer to the community through practical outreach initiatives. despite the transitional period, there was high trust in the current system. System development takes time. The existing system did not emerge overnight. Research involving beneficiaries is necessary to comprehend how the federalized health system influences the usage of health services. Next slide, please. These are the publications from our study, and there are many others which are in the process of publications. Thank you very much. Any questions?
Thanks, Pratik, for this informative presentation, and well done on keeping it on time. I open the floor to questions. So if there are any questions, please type your questions in the Q&A. Or if the panelists have any questions, then please raise your hand and come in. For you, Pratik, I have one question. Please, can you elaborate something on the participants and who your research participants were?
Well, actually, research participants, they are, the mostly health professionals who are working in the province level and local level. For example, health post in charge, immunization officer, staff nurse, health coordinator, and some other, the persons working in the NGO, but they are running, the different health-related programs. So these are the participants, and also the elected representatives, for example, mayor and some, the ward chair. So they are the local representatives from our study sites.
Thank you, Pratik, for answering the question. If there are any other questions, please type in the chat box or the Q&A. Oh, we have one question from the Q&A. There is question from Straight Touch Wong. She wants to ask, do you find different challenges between male and female participants?
Thank you for the questions. Only the challenge is among, the FCSB, female healthcare volunteers. They are, they had a low level of education, and a number of them, they are not confident, to communicate well. We approach them. Otherwise, there is no other issues.
Yeah. Thanks, Pratik. And we can take one last question. If not, then we'll move on to the next presentation. Thank you, Pratik, for this presentation. So moving on to the next presentation, we have Neeti Rao, who would be presenting next on intersectorality in public policy. So over to you, Neeti.
Thank you, Ketki, and thank you to the organizers for allowing me to present this work on behalf of my colleagues, Meenakshi Kushwaha, Lata Chilgod, and Pragati Hebbar. This work is actually examining 4 different intersectoral policies from India, and to see if there are lessons and challenges that we can draw that's applicable to developing intersectorality for India, but also more broadly among low and middle income countries. Next slide. So of course, the reason we're talking about intersectorality is that it's one of the implicit sort of foundations of the Sustainable Development Agenda. It's recognized it's something that's actually very critical to achieving many of those goals, but actually this kind of language on policy coherence, integration, intersectorality has in fact been ongoing for a long time, and it's been promoted by many development agencies, but also among the research community. But challenges like climate change, COVID-19, and so on have actually made it much more urgent and imperative. And for low and middle income countries, it might also be thought of as a potential way to optimize resources by achieving multiple sectoral goals through similar or a single processes. And we'll see if that actually pans out based on our analysis. Next slide. So we identified actually 4 different intersectoral schemes that are ongoing in India that are touch upon multiple sort of sectoral goals, including health goals in each of them. And they're also intersectoral in their implementation. And we use the scoping review method in order to identify the lessons as well as challenges, the positives and the negatives, and potentially arrive at frameworks that can be applicable to entrench and institutionalize intersectorality within policymaking spheres. And just to quickly give you what these 4 schemes are, we looked at the Ujjwala scheme, the Clean India Mission or the Swachh Bharat Mission, the midday meal scheme, and finally the Mahatma Gandhi National Rural Employment Guarantee Scheme. And each of them have, I'll just highlight the health objectives associated with each. The Ujjwala scheme, for example, is about increasing the use of clean fuel and therefore reducing indoor pollution and associated health risks. The Clean India Mission focuses on improving sanitation and reducing, for example, the incidence of diarrheal and choleral diseases among particularly the rural populations, but also improving urban sanitation. The midday meal scheme emphasizes nutrition, improving nutritional status of school-going children. And finally, the Rural Employment Guarantee Scheme actually tackles some of the socioeconomic determinants of health and is in that way one step removed, perhaps. Each of them actually have fairly identifiable discrete features and benefits, policy benefits associated with them. The Ujjwala scheme is about providing clean cooking fuel, in this case, liquefied petroleum gas, initially to the women among low-income households. The Clean India Mission is associated with the building of toilets and improving water supply and sanitation supply among all, again, low-income households particularly, but also among communities. The midday meal scheme is about provision of hot cooked meals to school children. And the Rural Employment Guarantee Scheme, as the name suggests, is about providing guaranteed employment to the rural poor for 100 days. Each of these schemes actually has multiple implementing partners in terms of both the ministries, but also even outside the government, multiple stakeholders involved, making them intersectoral. Next slide. But they also all saw some success and several challenges. And just to quickly touch upon some of them, the Ujjwala scheme, which did increase the use of, the number of LPG connections, clean fuel connections, and met its initial target. But the refill rates, so the continued usage of clean fuel over a longer period, actually faced many challenges, including the high cost of refills, the availability of households to be able to, obtain different usable cylinders. There were also sociocultural norms associated with who would use them, and cheaper fuels, actually, cooking fuels that were more readily available. The Swachh Bharat mission did increase the number of toilets that were built, and also, more importantly, perhaps brought the issue to the mainstream. Cleanliness and solid waste management and sanitation became a mainstream issue. But it did not necessarily correspond to a reduction in open defecation to the same degree. And the associated policy outcomes of waste segregation, improved sanitation was not necessarily fully realized. And challenges such as manual scavenging, once again, a sociocultural issue, does continue to persist, even if it did see a reduction in some areas of the country. The midday meals, similarly, which is actually the oldest of the 4 schemes and has been ongoing for a long time, has seen a great deal of success in improving school enrollment and retention, especially among girls, school children. And it does have, has had a positive impact on nutritional and associated learning outcomes. But the accountability mechanisms that are associated is highly variable from, different parts of the country. The infrastructure and the resources that are required, and also, sociocultural issues, for example, the menu of what the meal ought to be, whether or not who cooks the meal, caste-related challenges, all of that has continually plagued, and we have not yet been successful in eliminating those challenges. And finally, the National Rural Employment Guarantee Scheme, once again, has been seen as a potential climate adaptation or mitigation program. And most recently, during COVID, it did show that it was able to buffer rural distress in times where, among the lower income rural populations, especially in times of lockdown and crisis, for example. However, it continues to have challenges. One is the sustainability of the infrastructure that's built as part of this. I think from all of these four schemes, some of the good things that came up or some of the lessons that one could learn were that each of these all of our policies need to address the felt need of our target population, coming back to, what was highlighted during our keynote session about having people centricity. And I think these schemes were partially successful. For example, the midday meal scheme is about children. Parts of the Swachh Bharat and Ujjwala focus specifically on particular population groups. But implementation and actually consistently developing them required a high degree of political will, right from the top down. And even though there were evidence-based policy design components, it needed political will in order for them to be translated into cohesive policy design. And one of the things that actually helped with the successes was the simplicity of the benefits and clarity in terms of delivery and administration. Next slides. However, when in the absence of actually monitoring the outcomes along with just the outputs, the impacts are going to be limited because there are consistent problems of collective action and coordination. And this only can happen through iterative incremental movement. And finally, participation of the community at all stages of policy design, but also implementation on an ongoing long-term manner is crucial. Thank you. Over to you, Kirti. We'll skip that. I think I already said most of it.
Thanks, Nidhi, for this engaging presentation and for giving an insight on intersectional policy making. So I'll open the floor to question and answers. So if there are any Q&A, please type in the chat box or the Q&A section. I think there is one question which has been currently typed in, so we'll just wait for that. Okay, I don't think so there are any questions. So if anyone has any questions, please type in. Okay, there is one question from Mahalakshmi. Any insights on how we can make monitoring intersectoral policies?
Thank you, Mahalakshmi, for that question. So in fact, some of, from these policies already, there are some lessons on potentially intersectoral monitoring. So for example, the cleanliness audits that have been created actually involve multiple different stakeholders, both within the government in terms of different ministries, but also outside, in that a lot of NGOs, a lot of community actors have been involved in in monitoring progress. The same thing is also true, for example, in terms of the Rural Employment Guarantee Scheme. Once again, there is a great deal of different kinds of community actors, including community groups that have been monitoring. However, the challenge has been that a lot of this monitoring has focused on, as I said, the outputs that were associated rather than looking at outcomes. And secondly, even where there have been evaluations which have pointed to the challenges associated with these outcomes, for example, not promoting use of the toilets, even though there are physical toilets that have been built and that has been consistently monitored. it hasn't necessarily led to lower rates of defecation or eliminating defecation, even when sometimes they're announced as such. And so these kinds of evaluation, even when there is intersectorality associated with it, as we've seen, doesn't necessarily get amplified to the same extent. So while there is a need to ensure that there is monitoring and evaluation that is intersectoral, there's also equally a need to ensure that these different kinds of evaluative mechanisms are legitimized to the same degree. And there it is a matter of power dynamics, and that's maybe a separate question that requires ongoing work. But thank you.
Thanks, Neeti. There's one last question which we can take. So there's this question on what is your sense on intersectoral coordination and community level?
So thank you for that question. I think there are opportunities for intersectoral coordination. And again, some of this focus on the felt needs of the communities that some of these schemes actually do demonstrate to varying degrees is a indicator of that. Also, within communities, there are pre-existing mechanisms, so that the needs are actually within. So people are not thinking this is our health need or this is our need for something else. In fact, they're thinking of all of their needs within the same sort of social framework, and all of their interactions with various government or even non-governmental entry points tends to be along their needs rather than around sectoral initiatives. So I think there is in that part of actually intersectorality within the community already exists. What is missing to my mind is the responding to those needs in an intersectoral way. And I think that's where we need to figure out what those processes might be from a policymaker, policy implementation kind of perspective.
Thank you, Neeti, for this engaging presentation on intersectoral processes. Moving on to our next presentation, we have Ms. Dr. Bilkis Banu, who would be speaking on comprehensive approach for making health system function. So over to you, Bilkis.
Am I audible?
Yes, you are audible.
Okay, thank you so much. So thanks organizers for providing me this type of opportunity here to share this very burning topic with all of you. So good afternoon, everybody. This is Dr. Bilkis Banu, and I want to share with you a very important topic, that is comprehensive approaches and an effective way to make easier the health system functions. So can you please shift the next slide? Yes, I'm taking support from Ketki. Yeah, thank you. So at first, I want to move to you how actually the journey towards health is proceeding. So we know all that if there is any health problem, then we need to concentrate to improve health education, to improve our knowledge and attitude, and for ensuring the practice. But for ensuring the practice, we need to have three more components, that to ensure the support services from our family and community. This is one. Secondly, to ensure the support services from healthcare system, from healthcare providers, I mean. And third one, to ensure the support services from the policymakers. So with all these services, it is possible to enable people for the improvement in health. So this we can tell that, yes, this is the health promotion approach or comprehensive approach. Please go to the next slide. So in this, within these three components, we can say that, yes, this health system is one of the key component among this comprehensive approach. Please shift to next slide. So in this way, I already shared with you that we have three layers, actually. First layer is for the community people, where we can implement the mass awareness for improving their skills, their action, strengthen action, and a supportive environment. The second layer is to reorient health services for them by the training program. So that means that healthcare providers need to have proper training so that they would have skilled enough. And third one is to build healthy public policy that we can make by the advocacy meetings. Please shift to the next slide. So amongst, I already shared that, yes, within these three components, health services and health system is one of the crucial component. And keeping these three layers in our mind, when we found that gestational diabetes mellitus, hereinafter referred to GDM, in Bangladesh, it was in 2017, 35%. The problem was so high. So then we actually targeted with this project that strengthening efforts to tackle just GDM in Bangladesh. Next slide, please. So for this project, actually, we keep these 3 layers. For the community people, we conducted mass awareness. For the healthcare providers, we conducted training program. And for the policymakers, we conducted advocacy meeting. So this comprehensive approach, we actually considered within this project. Please, next slide. But within these 3 layers, you can understand that 3 layers, we had the goals in the project. And obviously, for these three sectors, we had need to develop the educational materials, which is culturally sensitive. But for the community people and for the policy makers, it was impossible to see the immediate impact. But for the healthcare providers, we could see the immediate impact. So the basic objective of the project was to assess the knowledge improvement of the health professionals after the training. Please, next slide. So in this project was covered in 2018 to 2021, and we actually covered in 64 districts of Bangladesh. And for the better convenience to conduct the project, we considered 4 adjacent districts in one cluster. So next slide, please. And I want to share with you how we did this project activities. For the community people, we did the roadshow as the community awareness campaign, and we did 32 roadshows in 64 districts. And for the health professionals, we did 16 symposium amongst the 64 districts. And for the healthcare providers, we had 3,427 healthcare providers. They are physicians, nurses, nutritionists, and health workers. All are related to provide the services for the GDM. So we considered them in the project, and we conducted 16 training programs in all over the country in the 64 districts. And for the policymakers, we conducted 64 advocacy meetings in 16 districts. Next slide, please. Here is you can see some of the glimpse of the project activities. Next slide. Roadshow, symposium, training program, and advocacy meeting. And we considered, for the immediate impact, we considered the training program, whether after the training, the change of knowledge was done for the healthcare providers or not. So we considered the semi-structured questionnaire, and we actually conducted a pre and post-training phase. And questionnaire included the knowledge on GDM and sociodemographic and their professional expert characteristics. Please, next slide. So now I want to share with you what we found as the impact after the training program amongst the health professionals. So initially, as we had 3,427 study participants, so most of them were Muslim and were female. Then, next slide. And we found that as the baseline characteristics, their professional expertise, they have very poor professional expertise in terms of training attendance, research experience, conference attendance, and published articles. We found very poor. Actually, most of the participants had they didn't attend actually in these components. Next slide, please. Now the main component, that is whether the immediate effect of the project, that whether the changes in knowledge after the training we found. Yes, for the all groups, physician, nurses, nutritionists, and community health worker, we found that after the training, there was significant improvement among the actually all the groups after the training program. Next slide, please. And we also found that with their knowledge improvement, the respondents who had, especially physicians and nurses, who had actually less aged and more educated.
I think we lost you for something.
They had more knowledge. Am I audible?
Yes, you're audible now.
Can you, Ketki, can you please change the slide? Yes. So actually, when we found, I shared with you that we tried to identify the impact result after the training program, whether they developed their knowledge or not. But also, in 2021, we tried to identify whether the whole comprehensive approach, increasing the scenario, the problem of GDM, gestational diabetes mellitus, whether the prevalence dropped down or not. Yes, we found from 2017, 35% it was, and we found 2021, it dropped down in 18%. So yes, comprehensive approach could actually improve the scenario, whole scenario. So our recommendation would be a similar approach could be implement to combat other diseases as a whole. So this thanks to all of you.
Thanks, Bilkis, for this interesting presentation on gestational diabetes management and health promotion. So I open the floor for question and answer. I think we have one question. So, what were the output you planned for advocacy meetings, immediate and long term?
Yeah. So at first I shared with you that we had three groups. One group for the community people, another group was for the healthcare provider, and third one was the policymakers. So immediate impact we could not assess for the policymakers and for the community people because we just conducted the awareness campaign and the advocacy meetings. But immediate impact we could take after the training program for the health professionals. So we waited for the national data when it was generated in 2021. So ultimate impact we found whether this comprehensive approach, which we conducted in all districts of our country, across our country, that actually reflected the main scenario that yes, the prevalence was dropped down. So immediate impact, we just considered for the advocacy meetings, their commitment of the policymakers, whether they are committed to implement all the prevention and management related information and services, whether they could facilitate for the healthcare providers and for the community people or not. So we just took their immediate commitment, nothing else.
Thanks, Bilkis. Are there any other questions? I have one question. Uh, can you tell us about what kind of confounding variables did you take into consideration while identifying the impact with the health promotion activities?
Yeah, thank you, Kitke, for your nice question. Actually, for the confounding variable here, we had to adjust the especially we had some of the professional expertise from them. So, so when the professional expertise, we actually considered them for this study while the analysis as confounding variable because they sometimes in some of the analysis we found them because of them this is increasing, some of them decreasing. So especially professional characteristics, we adjusted the confounding variable with the analysis part.
Thanks, Bilkis.
Okay.
So I think there's one more question, and this would be the last question that we take. So the question is, does your country have any program related to gestational diabetes mellitus?
Yes, we have. Maybe you know that we have in Bangladesh we have very structured services for the diabetic patients. We have Diabetic Association of Bangladesh, and under this Diabetic Association of Bangladesh, we have in the 64 districts we have 64 affiliated organizations. So actually, we conducted this project also with the help of them, so that we could cover the whole country. And with this structured program, it is possible to make available the services to all of them. But still, there is the question whether the other supports are available or not. Because although we have the services, but if the community people will not receive it properly, and also the policymakers all time, if they are not aware to provide the resource services in the proper places, so it's not possible to ensure actually to combat any kind of health problem. So here is gap still is going on because we are overpopulated country, you know.
Yeah. Thank you, Bilkis. There is one more question in the chat box, but in the interest of time, I would request you to type your answer in the chat box to address Divya's question.
Okay, how did you assess impact of other components like advocacy meetings, roadshow, and poster presentation? I already reply of this answer of the question, because we could actually assess the training programs. But I shared with you that for the advocacy meeting, we actually tried to identify the immediate impact, whether they were committed or not. For the roadshow poster presentations, we actually considered how many posters we could give the community people. So these are not actually statistically identifying any variables, so that we try to identify later the ultimate impact for these components. But for the training program, we just identified immediate impact. Divya, thank you for your question.
Thank you, Bilkis. So moving on to the last presentation of our oral presentation. So I would invite Riddhi Jain to talk about uh, next presentation, which is similar to, which is related topics to the previous presentation, that is on gestational diabetes mellitus and assessment of risk factors. So over to you, Riddhi.
Hello. Thank you, Ketki, for providing me this opportunity. And a very good afternoon to all present here. Myself, Dr. Riddhi. I'm a public health scholar from AIMS Jodhpur, India. So the topic for my today's presentation is the assessment of outcomes, risk factors among gestational diabetes mellitus and non-gestational diabetes mellitus mother delivered at a tertiary care health facility in Western Rajasthan. Next slide, please. So gestational diabetes mellitus is a type of diabetes that develops during pregnancy and poses a high risk to the mother and newborn. Its prevalence ranges from 4 to 41% in India, as it is due to difference in diagnostic tools with different the different diagnostic tools has been used for determining its prevalence. And its variation is due to also the residence area like urban, semi-urban and rural. And as per the Ministry of Health and Family Welfare guidelines, there is a need to highlight the diagnosis and management early stage of GDM. Next slide, please. So for this, the study was done to assess the proportion, risk factor, and outcome which are associated with gestational diabetes mellitus and non-gestational diabetes mellitus mothers. Next slide, please. For this, a cross-sectional study was conducted in a labor room and IPD wards at a tertiary care health facility in Jodhpur, and all the delivered females above 18 years of age were interviewed as per the inclusion criteria. And the female with twin pregnancy, their chronic conditions such as HIV, AIDS, TB, previous diabetic females, heart disease, kidney disease are excluded in this study. Next slide, please. So sample size has been calculated by taking 17.8% as a prevalence. And now coming to the sampling procedure, the data is procured from the labor room register, and then the consent has been taken from all the delivered females as per the inclusion criteria. The analysis was done by using SPSS software. Next slide, please. For this, the consecutive sampling is used, and a semi-structured questionnaire was used to interview these 500 delivered females. Now, coming to the result. Next slide, please. The prevalence of GDM was found to be 20.8%, which was approximately 21%. And the mean age was significantly higher in GDM as compared to non-GDM females. Next slide, please. Further, the risk factor was seen, and it was found that the age more than 25 years, pre-pregnancy BMI, history of PCOS, family history of diabetes mellitus, previous history of birth weight more than 4 kg was found significantly with development of GDM, and other factors such as previous history of abortion, previous history of GDM, multigravida are not found to be significantly associated. Next slide, please. So complication in terms of both mother and newborn were addressed, and in mother, it was found that cesarean section, induced labor, shows are significantly associated with GDM, while the factor such as assisted vaginal delivery, premature rupture of membrane, PROM, antepartum or postpartum hemorrhage, perineal or cervical tear was not found to be significantly associated. Next slide, please. The newborn complications such as small for gestational age babies, NICU admission, respiratory distress and pneumonia are significantly associated with the GDM as compared to the non-GDM. Next slide, please. Finally, the logistic regression was done to assess the risk factor for development of GDM, and it was found that the family history of diabetes mellitus is a sole risk factor for the GDM development in this study. Next slide, please. To conclude this, we need to tackle the risk for adverse obstetric and neonatal outcomes, which can be prevented by taking control measures such as targeting screening and early identification. So it is recommended to take proactive measures like monitoring and other intervention to reduce its risk. Next. Thank you. Over to you, Ketki.
Thanks, Riddhi, for this presentation. So I open the floor. I'm keeping well on time. So I open the floor for question and answer. If there are any questions, please type it in the Q&A section. In the meantime, I have one question for you. Can you briefly elaborate on what is consecutive sampling and how did you take into consideration bias associated with consecutive sampling in your findings?
Yeah. So the consecutive sampling is a type of sampling in which we are taking all the delivered females until the sample size has been achieved. So I am using the consecutive sampling until my 500 delivered females has been achieved.
Okay, and what was the bias which is associated with such sampling, and how do you take that
Mainly
into
like it's a incidence prevalence bias which are very much prominent in cross-sectional studies. So I am taking all the females who are delivered here, who are delivered at a tertiary care health facility. So I think uh, it is not like that we are only considering all the female or only those females who have the GDM. So that's why I think I don't have the incident prevalence bias in this study.
Thank you, Riddhi. Are there any other questions? Please type it in the Q&A section. I think there are no further questions. So we move on to our next session. So our next session is lightning talks. This talks would be for 3 minutes presentation, and this will be followed by 2 minutes of Q&A. So we have 4 lightning talks in this session, and we would request participants to keep to the time limit. So going on to our first presentation, we have a first lightning talk by Ruchi, who would be talking on ensuring health and ensuring future, a comprehensive study of COVID-19 survivors. Over to you, Ruchi.
Yes, good afternoon, everyone. I hope I am audible.
Yes, you are audible.
Okay, so good afternoon, everyone. My name is Ruchi Thakur, and I'm a research scholar at MIT University, Noida. And today I will be presenting Ensuring Health, Ensuring Future, a comprehensive study of COVID-19 survivors. Next slide. So, as we all know that the COVID-19 has had a profound impact on the global healthcare system, and due to which many individuals have contracted the virus and millions have lost their lives. As per the World Bank data report, India was the third largest country that has the highest out-of-pocket expenditure, which was around 50.59% in 2020 as compared to the other developing countries. The high out-of-pocket expenditure on healthcare are imposing financial hardships to around 55 million people, with over 17% population experiencing catastrophic health expenses on annual basis. As per the National Family Health Survey 5 data, 2019 to 21, there were around 41% of the Indian households were having any one of their members insured under any of the health insurance scheme. This percentage has been increased from the previous years, that is NFHS 4 data, but still the overall percentage or overall coverage is very less. Next slide. So in my study, there are basically three objectives. First is to assess the status of health insurance in the Delhi NCR during the COVID-19 pandemic, to find the association between the awareness, attitude, utilization of health insurance with the selected socio-demographic variables, and to understand the factors which were influencing the uptake of health insurance. So this is a retrospective cross-sectional study, and it was conducted last year from Jan to December 2023, and random sampling method was used in this. And the individuals who were more than 18 years of age and they were COVID-19 positive and were hospitalized were taken under the were recruited in this study. So total 300 participants, we got the responses. Next slide. So the results include there were around 300 participants. Majority of them were males, that is 76%. Around 63.6% participants belongs to less than 50 years of age, and 61.6% attained the graduation or higher level education. Most of the participants were employed in the private sector, and 61.3% participants have the household income ranging between 50,000 to 1.5 lakhs. So this study found that majority, that is 86.6% of the participants, were aware about the health insurance schemes. And 88.5% believe that investing in the health insurance is important. Among the participants who were aware about the health insurance, only 65.3% were actively enrolled in any private or government health insurance. And among those enrolled, 52.5% used their health insurance during the pandemic. Next slide.
Can you
ಯಾವ್ದು ವರ್ಕ್ ಆಗ್ತಿಲ್ಲ
uh,
ಫೋನಿಂದ
up? Can you
So these are the main reasons.
ಆಗಿಲ್ಲ ಅಲ್ವಾ ಸ್ವಲ್ಪ ಯಾರಿಗಾದ್ರೂ ಕೇಳಿ ಅಲ್ಲ ಒಂಚೂರು ಕಾಣಿಸ್ತಿಲ್ಲ ನಂಗೆ ಮೋಸ್ಟ್ಲಿ ಅವರು ಮೀಟಿಂಗ್ ಹೋಗಿದ್ದಾರೆ ಅನ್ಸುತ್ತೆ ಐ ಹ್ಯಾವ್ ನೋ ಐಡಿಯಾ
So these are the main reasons for not enrolling in the health insurance. First is the lack of knowledge. Second is financial. I thought somebody muted me.
Yeah, I think that was a mistake. Please carry on.
Okay. So these are the reasons for not enrolling in the health insurance. First is lack of knowledge. Second is financial constraints. Third is most of the health insurance covered partial treatment. Fourth one is limited disease coverage. And the last one is not interested to invest in the health insurance policies. So these are the five main reasons which I got from the participants. Next slide.
Ruchi, please can you wrap it up in 1 minute so that we have time for Q&A?
Okay. Okay, all right. So I have found association. I have selected some of the socio-demographic variables like age, employment sector, income, and type of the hospital patient got admitted. So basically, the age, income, employment sector, and the type of the hospital in which patient got admitted, they were significantly associated with the knowledge, attitude, and utilization of the health insurance. So these are the tables that I have put in. So I'm not going to explain it. So you can just move to the last slide, the conclusion. These are the tables like education, household income, and these were significantly influencing the patient's knowledge, attitude, and utilization. So the main conclusion of the study is that the significant proportion of the participants were aware about the health insurance, but only the 65.3% were actively enrolled in any insurance policy, and around half, that is 52%, utilized their insurance during the pandemic. So the main barriers that I have already discussed in last slides, that were the main barriers because of which they didn't enroll. And there are certain social demographic factors like age, education, income, household, or hospital type influences their awareness, perception, and utilization. So the study emphasized the need for enhancing the information, education, and communication services to raise the uptake of health insurance in Indian populace. So next slide is the references. Thank you so much for your time.
Thank you, Ruchi. So if there are any questions, please type it in the Q&A. In the meantime, I just have one question. So can you elaborate whether the health insurance you were looking at and what kind of health insurance were there, whether they were public insurance or whether they were private health insurance?
For the study, you are asking that most of the
Yeah, for
participants.
the study.
Okay, so all right. So actually, most of the participants were enrolled in the government insurances, and there were less proportion of the participants who got enrolled in the private insurance. So the main reason for not utilizing the insurance is that they got hospitalized in the government hospitals, so where they didn't use their health insurance card because it is not necessary there. So, and in the private hospitals, all those who got admitted, most of them have utilized their health insurance policy.
Thanks, Ruchi. So we go on to our next presentation. We have Angel, who would be speaking on structural respectful maternity care. So, Angel, over to you.
Thanks, Ketki. A very good afternoon to everyone. I'm Angel Sudha, serving as a team lead and pursuing my PhD at the Institute of Public Health. I'm thrilled today to share with you all the findings from our evaluation of the first midwifery training program in Telangana, India, which is funded by UNICEF. Next slide, please. Yeah, so India has made significant strides in the reduction of the maternal mortality. However, quality of care has been a concern. Obstetric violence and irrational use of medical interventions, especially cesarean sections, has been long-standing challenges in the field of maternal health care. So, recognizing the crucial role the midwife plays in providing respectful maternity care by offering normal birthing with minimal interventions, the government of Telangana, in partnership with UNICEF and Fernandez Hospital, brought about a structural reform in the state public health system by introducing a professional midwifery cadre, and which had the 30 existing government staff nurses, which were transformed as professional midwives by the end of 18 months training program, which involved theoretical learnings, role model mentorship, and then hands-on training. And Institute of Public Health, in partnership with UNICEF, has evaluated this training program for over 4 years, starting with during the training program and after the training program. And so this aligns with the topic aligns with the HSR sub-theme of 2, that is transforming a structural change, addressing disrespect and abuse, thereby contributing to a just health system. Next slide, please, Ketki. So the main objectives of the evaluation was to assess the competencies of the midwives in delivering respectful care, and also to identify the different facilitators and the barriers for establishing the midwife-led maternity services. And so the table here highlights the different tools that we used and the amount of data that we have collected over a period of 1 year. We used both qualitative and quantitative data. The quantitative data was analyzed using percentages and averages, and qualitative by thematic analysis. And next slide, please, Ketri. So here we identified that the midwives were able to deliver respectful maternity care Even after 1 year of the training program has been completed, they were providing competent and dedicated, respectful care, which we found as a significant change in the care delivery. And there was more emphasis of understanding the pregnant women on as mothers rather than patients, also offering them privacy, freedom of choice, the empathy, and offering various birthing positions, giving them the autonomy to choose, and encouraging them the mobility during labor. So these were the different findings that were highlighted and that stood out in our findings. And one, as aptly said, from many mothers and different people who have observed the midwives delivering care have recognized the care that is provided, and this initiative gained wide recognition among the different stakeholders. And as one of the mothers said, that she felt like she has been treated as a family member with love and they were encouraging them with counseling and motivation. So there were several other quotes that highlighted the care that were received by the mothers. Next slide, please, Katie. And the midwifery gained wide recognition around the state, and this stood as a model for replication and scaling up of this initiative across the country. But next slide, please. Yeah, but midwifery faced challenges in an unstructured health system. So poor facility preparation, lack of professional guidelines, role confusion, and limited resources. So because when there was no enough sensitization provided in the healthcare facilities, they were being posted as in general duties in the OTs. So, but they were not used appropriately for what they are trained for. So which resulted in the deviation in the midwifery model of care. And they also had the fear of losing skills, and a professional dissatisfaction was widely noted among the midwives, as aptly said by some few midwives, that they don't even have a uniform, they don't have a cadre, they have no facilities to do what they're supposed to do. So this has led to inability to fully practice midwifery. So to conclude, next slide, please. So midwifery stood out for compassionate expertise, gaining wide appreciation for their competencies and care initiatives, but challenges in unprepared health system persist. The pivotal role that helps in the success of this program will be in establishing a well-prepared health system that facilitates this structural change. Yeah, that's it. And thank you so much for this opportunity, and I'm open for any questions.
Thank you, Angel, for this interesting presentation, and well done for connecting it with the HSR 2024 sub-team. I open the floor to Q&A. Thanks, Angel. I don't think so there are any questions. Just one last question on my end. How do you connect this midwifery training program with a larger health system?
Katie, I lost the second bit. The first thing I understood, that how do you connect with the larger health system? So fine. Yeah, fine.
I was just asking about the impact of your business. Sorry.
Yeah, fine. So the intention was to provide respectful care and also to reduce the burden on the tertiary facilities, so that by introducing midwifery, when the midwife is able to provide the care in promoting normal births at the primary level, so the patients will not be referred too much to the tertiary level facilities. So that is and also to also reduce the burden of cesarean section deliveries in the tertiary level facilities. So these were different other objectives, the main objectives of introducing the midwifery program. And yes, definitely this will have, if the midwives are able to provide the adequate care at the primary level facilities, and it will reduce the burden on the tertiary facilities, and thereby reducing the unnecessary need for medical interventions. Hope I could answer your question.
Thanks, Angel, for this, and thank you for answering my question. So we move on to our second last presentation. We have Dr. Susaina Mitra from International Institute of Migration and Development, India, and she would be talking on migrants' inclusion in health services. So over to you, Susaina.
Thanks, Ketiki. Am I audible, visible, everything fine?
Yeah,
Yeah?
everything is
All
fine. Yeah.
right. Okay, thank you. So I'm Susanna Mitra, and briefly, my background is public policy. I have worked, my work has been related to National TB elimination program and malaria control program and public health surveillance. And from that, perspective, I have developed this research agenda. And thank you for this opportunity for, to the organizers to allow me to present my work. Yes, next slide, please. Thank you, Kate. Yeah. We can skip this. It's just the outline. Next slide. Yeah. So basically, we are talking of a huge migrant population worldwide. Country is facing refugees, asylum seekers, informal migrants, voluntary migrants, and the main problem of healthcare services for migrants is basically about their visibility in healthcare services. So because every country has different, infrastructure in health information system, the migrant community, they often become hard to reach for these, programmatic interventions in the host countries or the destination countries. So some of them are the limited visibility in national and regional health services is the settings. They might be disrupted in war zones, inadequate provisions, health information system is they remain unrecognized in the health services management, host societies, they may be socially discriminated, limited services provided to them, and political support in many countries, there are exclusionary policies towards migrants. Yeah, next slide, please. So the problem is the enumeration of migrants in health services, which ultimately into their inclusion and for their health equity. So here I have underlined three main concepts that I'm going to use. The poor information systems that face issues of identifying migrants, poor disaggregation of migrant population groups, and thereby lacking in clinical and non-clinical informational integration. So the robustness and representativeness in the national health information systems, the inadequate program response to marginalization, discrimination, that the structural factors that they face and that leads to the health disadvantages, that is the programs become insensitive to their circumstances, and finally the disrupted health services like the geographical reach, the poor communication networks that often occur in migrant settings. Yeah, next please. So as you can see, there are several reasons that have been identified in the literature about migrants' exclusion from health services. And one of my experience and my understanding over the last few years has been all these factors actually create the disconnect between the evidence building or the system or in the national programs, and that's where the issue of invisibility comes in. And so they cannot address the problem. So there is a disconnect. So outbreaks go unchecked. So one of the main issues would be to increase migrant visibility for effective and accessible health services is therefore important. Next slide, please. So basically, it's about evidence development. This research is about understanding how the migrant setting, the migrant's own experiences, personal, social, is a factor, is a determinant in evidence building, programmatic evidence building, in whatever health interventions you might undertake, in disease, vaccination, the circumstances, the personal experience is a determinant of evidence development for the health program. So they need a pioneering evidence base for sustained engagement with the population to mainstream them in the national health programs. So the four identified are the new modes of identity credentials of migrants. The evidence development has to shift from outcome to process. It must resonate with scale implementation in large diverse contexts, not just experimental results, and the account for causal pathways, the mechanisms of action that ultimately kind of the social setting to finally inclusion in the health information system. There is a lot of complex pathways that the linkages that must be accounted for. Yeah, next please.
Thanks, Susanna, but please can you wrap it up in another minute?
Yeah. Okay. So I have designed this research around policy designing, which is a broad research. It is based on designing based on research evidence, not just the hardcore rigorous scientific evidence, but from practice and policy implementation, from political realities and public debates, from stakeholders, activists, patients, everybody. Yeah, next. So the research aim has been to develop methodological tool for evidence-informed program designing for migrants' health services. Next, please. So the three main concepts that needs to come in for this conceptual tool is identifying disparities through data, the representativeness. So we have to look into the around gender, ethnicity, whatever. And then we have to understand the social determinants of health that is a barrier to their program access or healthcare access, the sensitivity of the programs, and finally, equity in evidence-informed decision-making, the coverage. How much and to what extent a larger population can be covered in the evidence-based information decision-making about the coverage of migrants. Yeah, next, please. So here, the research aim is representative evidence services, sensitive and adequate coverage in the services. The purpose is to understand the disparities, understand how they can be sensitive and how they can be covered. So health information system estimation, appropriateness of health services, program adaptability. These are the concepts. And then we come into the dimensions and what kind of methodology will help us find the evidence. This is a expansion of it, and this is the conceptual tool. It is a designing tool to help understand the various roadmaps and the pathways to connect all the elements in designing programs and health services. Yeah, next, please.
Thanks, Susanna. Can you just conclude? Yeah.
Yeah. So no, the earlier one. Just one second. The earlier slide. So this is one publication we had. We did validated the conceptual tool, and we kind of understood that how programs can become more representative of the target population. Yeah. Next slide. Next, please. And this is a work in progress. We are developing different methods. Yeah. Next, please. Conclusion, this designing tool will provide pathways for research, policy, and practice for advancing global health equity. It is for mechanisms for inclusive governance, capacity building, and community engagement. And it will bring in a larger group of, participants in decision making. Yeah. Next. Yeah, this is the research diagram. Thank you.
Yeah, thank you, Susanna. If you have any questions, please type in the question and answer section, or you can also, for the panelists, you can also type in the chat. So, I don't see any questions coming in. there are any questions, please type it in the Q&A, and Susanna will answer directly over the Q&A and type for answer over there. We thanks Susanna for this interesting presentation, and
Thank you.
We move on to our next presentation. Our last presentation is by Dr. Suman Swan. He's from India again, and he would be talking on global warming to global boiling's impact on urban population health. So over to you, Dr. Suman.
Good afternoon. Thank you so much, Dr. Ketki had given an opportunity to present this paper on the global warming to global boiling's impact on the urban population health. Particularly, we will focus on the policy programs and sustainable actions. Next, please. So, if you look into the data of the Indian perspective, India is the high focused country, particularly in terms of the climate change. Next, please. If you'll see the in the burden of the disease in the mortality, particularly India is also in the highest in terms of the mortality in terms of the climate change. Next, please. So if you look into data of this all this climatic data designed by the various organizations and the World Meteorological Department, you will see the hotter is going, the world is going hotter by hotter. Particularly, the India has been increasing. The temperature has been increasing so drastically from the year by year. So this 2023 is called as the hottest year in the year. Next, please. So if you look into this data, in every year we are experiencing 2.5% to 2.9% of the increase of the increase of the temperatures. Next, please. So what is the particularly what is the implications? Yes, this is now the extreme weather is becoming the new normals. So recently the Secretary General of the UN has warned that the era of global warming has already ended, and now the era of the global boiling has already arrived. So based on the 173 years of the data from the 2015 to 2022, the data witnessed the 8 warmest years on records. So it has been observed that the global temperature will temporarily exceed the 1.5% threshold above pre-industrial levels, and for at least one of the 5 years. So the Secretary General urged all the countries, particularly to push to reach net zero emissions by mid-century, and also countries must unite to accelerate the just and equitable transition from fossil fuel to renewable energy, while stopping the oil and gas expansion and phasing out the coal by 2040. We will try to reduce the emission levels. And nowadays, if you look into the COP28, COP and remaining COP, the nowadays the climate change is taking place very central place in all these national and international negotiation and policies to particularly minimize the impacts. So it's and including the urban health area. Next, please. So if you look into the data of this urban setup forecasted by the census of India, the urban population is almost the 30% in the near future. It will going the more. So the if you look all these countries, all the South Indian regions and all the urban population residing in the more, they are mostly in the coastal cities. Next, please. If you look into the cities in the year 2018 and 2013 years, population in terms of the geography and in terms of the populations, the population is going is getting population is getting more concentrated in the urban cities. Next, please. So if you look into this demographic data, if you will see the geriatric populations, particularly the people in the older populations and the young populations, this is the recent the population data designed by the Census of India and various organizations. So they projected that most of the peoples in the young age, they are now sitting in the urban setups. Next, please. So, what is the urban demography? If you look into the urban demography, so in crux, the urbanization is one of the most significant trend in the 21st century. So, India is the second largest urban system in the world, with almost 11% of the total global urban populations living in the urban cities. So, the proportion of the urban population increased from 10.8% to 31% percentage in 2022, and it is expected to increase 50% in next decades. So the urban population grew almost 91 million to, in terms of population, 377 million in between. So the urban population growth is expected to contribute to about 37% of the total population, increasing by by 236, according to estimated by the Ministry of Health. So by 2050, if you look into the terms of the volume, the additional 400 million people are expected to live in the urban cities. So it is doubling in 4 decades from 2014. Next, please. So if you look into the growth rate, all India population are growing at the 2%. In terms of the urban populations, growing at 2.75%, and the large cities growing in the 4%. If you look into the slum area, they are growing at the 5 to 6% of the populations. Next, please.
Samantha, can you please wrap up your presentation on another 1 or 2 minutes?
Okay, sure. Thank you. Next, please. So if you look into the temperature, according to the volume of this population, also the volume of the temperature also going rise. Now we'll near future we'll going to experience 5 to 7% increase in the temperatures. Next, please. So what is the impact? The impact is the speed of the change due to the climate is very intensive and very deeper. The unbearable heat and cold waves, snow melt and glacier lake burst is most common in the urban area. Urban heat island effect is cities is more due to the high population density, limited vegetation, green cover and concentration of the concrete structures. So the massive flooding due to the heavy rain and intensive rain within a very short period of the time, and that occurs in the landslide also. Drought became very tense, increased malnutrition related health disorders such as child stunting. Here, heat waves contribute to the rise in the morbidity, mortality, and injury in urban areas. Lack of sanitation is also effects in the particular increase in the cholera, typhoid, diarrheal diseases. Warmer cities increasing respiratory diseases. Climate change now increase the burden of the vector-borne diseases in dengue, malaria, and also the filarial diseases. Next, please. So, according to the World Meteorological Organization, various forecasting and all, mostly in the urban cities, Calcutta and Chennai and Calcutta, they are the most vulnerable. Next, please. So who all are the particular suffering due to the increasing the heat waves, particularly the slum population, comorbidity peoples, women, elderly, children, homeless, rag pickers, street children, rickshaw pullers, construction and brick workers, sex workers, and temporary migrants. They are more the vulnerable population. Next, please.
Please, can you conclude the presentation?
Yeah. Government has also implemented so many policies to minimize the impacts. 8 policies: National Solar Mission, National Mission of Enhanced Efficiency, Mission Sustainable Habitat, Water Mission. Next, please. So next, please. So urban housing also implemented one of the program is called as the National Mission for Sustainable Agriculture to Climate Sustainable Cities. Next, please. Climate cities, smart city assessment framework, climate cities alliances. Next, please. So what are the future plans? So future plan how to minimize the impact in the climate change. So it needs the vulnerability assessment of the urban cities and action, and it needs the climate action plan. This is the urgent of the urgent of the action required. The climate inclusive smart city to achieve the sustainable development goals, and also communitization of the programs, particularly involvement of the Mahila Arogya Samiti. This will be the most effective climate resilience health system required to create a holistic climate-centric health database for better decision making. Massive afforestation required, promotion of innovative technology, involvement of the civil society monitoring framework and the energy, particularly focus on the renewable energy, solar, nuclear, hydro, and wind. Transport, e-vehicles, and e-energy efficiency decision making. Smart city waste management, particularly should focus on the waste management and sustainable urbanizations. Strengthening the e-governance system, and the major objective, our main objective is to save the mankind and increase the happiness index, and also to protect our cities to aim to achieve the zero net emissions by 2070 by targeted by the government of India. Thank you so much. Any questions? I will happy to answer.
Thank you, Vinay, for this pertaining topic and for presenting on it. So, any question and answer, please type it in the chat box. So there is one question. Action taken in India for climate resilient health system. Can you answer that, Sumant?
Yes, the government has taken many initiative. We have the 8 action plans. So national, excuse me. Yes, we have the 8 action plans, government in the normal, and also the other smart cities, smart resilience health systems. We have so many actions taken by the government, but it needs the community involvement. The communitization of the program is required, particularly to minimize the impacts. Due to the actual shortage of the time, actually I lost everything. Everything I will share the PPT mentioned in all the programs in this PPT.
Uh, Thank you, Samantha, for this. So, thank you. I would like to thank all the presenters for today's session for presenting on your topic. And uh, to conclude, I would just go back to a few slides. I just wanted to share on how to join the health system global and what are the benefits for joining the health systems global network. So, these are different ways of joining us through uh, through symposiums, through global regional events, and through the Google group. So if you would like to join in, please become a member at Health Systems Global. And if you want to become a member of the Health System, the HSG Asia Pacific region, please write to us and we would add you to the Google group. Also follow us on Facebook, LinkedIn, and Twitter or X. Thank you all. And for tomorrow's session, we have a very interesting panel lined up on knowledge for just health system. The panelists would talk on different topics on radical listening, community participatory action research for translating practice into evidence for developing climate resilient system. So looking forward to join you. We also have a couple of uh, oral presentation lined up tomorrow as well. So looking forward to a great joining and to a great session tomorrow. Uh, for Samantha, there is one question for you in the chat box. If you want to type your answer in that, it would be great.
Sure, sure. Thank you. I'll